No questions? Okay, so let me tell you what's happening. This week, of course, we're going to be doing module number 3, which is infective and inflammatory conditions of the heart. This coming Sunday at 11:59, I'm asking you to complete the RN Targeted Med-Surg Cardiovascular Online Practice 2019. You will be accessing that on the ATI platform, and there's nothing due on Blackboard this week. Next week, we are going to be finishing up our first 4 modules. The first 4 modules are going to comprise exam number 1, and as you know, exam number 1 is going to be on June the 10th. So hopefully you have already finished up infective and inflammatory, and this is a review for you. But if not, I want you to get right on the cardiac dysrhythmias, because I find that most people, and I know that you guys haven't been exposed to this, this is is a little bit of a tricky subject for you, just learning that. And I want you to know that when you leave this class, you will be continuing cardiac dysrhythmias in S2, but in no way will you be an EKG expert when you leave this program, and it's going to take a very long time for you to become an EKG expert. So I want you to be patient and loving with yourself, because this does take time. And so probably next week or later this week, I'll just send you something on the announcement board, just to make sure that you know which rhythms you're going to be responsible for, and so that you don't go outside that box and get in the weeds too deep, is what I'm telling you. I want you to learn the basics, and I want you to learn the basics well. Next week, you will have 2 things that will be required of you. There will be a Blackboard quiz, quiz number 3, and then there'll also be a review for you on ATI. Next week I will be publishing exam 1 blueprint, and then we will be getting ready for our first exam. Those of you who may need a little bit of extra support, please don't forget about tutoring. Please don't forget about the availability of personal, individual, one-on-one tutoring through the Student Success Center if you need that, as well as group tutoring with Miss Wilson. Anybody have any questions before I start my slideshow today? You guys are quiet today. Not for long. We're gonna be a little bit more interactive. Next week, I'll be doing a lot of talking because it will be new material for you. But today, we're going to do a case study, because I think that sometimes that is a good way for you to imprint, for you to actually apply the knowledge that you're learning. So today, of course, we're going to be talking about infective and inflammatory cardiac conditions. Specifically, we're going to be talking about endocarditis, infective endocarditis. We'll be talking about pericarditis and the complications associated with pericarditis. So what's endocarditis? What is the definition of endocarditis? Okay, of the inner layer. So very good. And it can be an infection, and most likely in endocarditis, it will be an infective agent, but it can be inflammatory. So don't forget that you can have inflammation and or infection. If you have infection, you're going to have inflammation, but sometimes there's no bacteria. So it's more of an inflammation. So remember that the endocardium is that very thin, smooth layer of lining that's going to line your heart and your the chambers of your heart and the valves. So it's important, because that inflammatory process in endocarditis could affect any one of the 4 valves, the septum, the area between the ventricular chambers, and then the chordae tendineae. And if you remember, I told you that the chordae tendineae was that spring door. I call it the spring door on the back side of the valves that give it the tension, that gives it the ability to open and close. And those chordae tendineae are buried in the papillary muscle. That's why we're always concerned if there's a papillary muscle rupture, like during an MI, for example, because those chordae tendineae will be released, and we don't necessarily want that. So I'm going to give you 2 minutes. I'm going to set a timer, and I want you guys to take 2 minutes to read the case study. And then I just want you to write down on a piece of paper right next to you, what are the significant things that put this patient, we know that this patient here has infective endocarditis, but I want you to tell me some things that put him at greater risk for infective endocarditis. So let's take 2 minutes, and when the timer rings, then we'll talk about that. Do you mean JF? Okay. I was like, do I have the right slide up here? Okay, that, oh, PT, thank you, Abby, thank you for that. Okay, so we've been 2 minutes. So I want you to tell me some things that really stand out with you in this case scenario, besides everything. I want you to be a little bit more specific. He had a staph infection about a year and a half ago. He has staph and strep. So we've identified that the two organisms, but he has. I want you to be thinking about what his past medical history is, and how that affects. Okay, he's immunodeficient for sure. So that means that he's got a valve disorder. He's got pre-existing conditions. So of course, whenever we have an immunodeficiency, no matter whether or not that it's genetic or whether or not it's acquired, we know that the immune system is not up to speed. It's not able to surveillance the body well, and it's going to allow these infective agents to take over. So when we talk about patients who have pre-existing valvular disease, like in this particular case, this man has aortic stenosis, we know that there's a propensity for vegetations to occur on those valve leaflets. And then sometimes they could be sterile, or sometimes they become infected. So that would be the difference between infective and non-infective, because you can have vegetations that are sterile. However, when you do have a sterile vegetation, just know that the patient still is at risk for an emboli, an embolism, because those vegetations can break off. So we know that. So what do you think about these two agents that this patient has, staph and strep? What do you know about that? What do you know about staph and strep with regard to infective endocarditis? What about the causative agents? What are they? It causes infection. Yeah, these are the two known most. Strep can cause rheumatic fever, but Staph aureus and Strep viridans is the most common two types of organisms that lead to infective endocarditis. It can also be caused from a virus. It also can be caused from fungus. And then we also have somebody mentioned that this patient is malnourished. And so that is super important as well, because we know that that healing does not happen without the proper building blocks, which is protein. And so we know also that this patient has relentless nausea and vomiting. And she also has coronary artery disease. What else about her? She's got the classic chills, high fever, fatigue, malaise, joint pain, headache, all the things that go along with it. She does have renal failure. Does she, Abby? I can't remember. I'm looking for it in here. I believe you, but we know that
second paragraph.
Yeah, I see it. Yeah, I see it. She's in renal failure. Thank you. And also, she has a central line. Okay, she has a central, or she has either a midline or a central line. She has a PICC line. So that also puts our patients at greater risk, right? She has a catheter, so she has a PICC line. And if she's in it, and we don't know what stage renal failure that she's in. I assume it's stage 5. And I can assume that maybe perhaps the patient is on dialysis, which would even put her at greater risk. Okay, so those vegetations that I was talking about just a little bit ago about whether they're infective or whether they're sterile. What happens is that there's a collection. Those vegetations are made from like fibrin, the fibrin that's in our blood, and leukocytes, white blood cells, and platelets, and sometimes microbes. That's what forms those vegetations. And so sometimes those vegetations can break off and they can cause emboli. And so when we have infective emboli, and especially with infective endocarditis, we have specific signs and symptoms that the patient's going to display that's going to be able to give us some insight into that. So I want you to remember that the risk factors for infective endocarditis can be cardiac, they can be non-cardiac, and sometimes they could be procedural. Anytime that you're dealing with, like, let's say, for example, dental procedures. That's one of the greatest ways for this to happen. So at one time, and somebody said rheumatic fever. I don't remember who it was, and we know that rheumatic fever is caused by strep, but it used to be a very high cause of infective endocarditis, but now it's about less than 10%. And remember that your patients, the older that they are, the more risk that they have. And we know that about 50% of our older population have calcified aortic stenosis already. So that means that they have calcium around the annulus. We also have to consider our IV drug users, people that have had a valve replacement, somebody who has a prosthetic valve, for example, or they have a congenital heart defect. So I think we've covered mainly the people that are at risk for infective endocarditis. Questions? Comments? Anything to add? Okay. All right. And so we talked about the possible causes of IE. So we talked about some of the pathophysiology, and I do have a pathophysiology slide for you, so we'll defer to that for a minute. And then we talked about the risk factors, and we talked about the patient's risk factors. So we've covered this slide. Okay. So I do have a slide, and this comes directly from Lewis, and this is just infective or vegetations rather on the mitral valve, and that's what they look like. So when sometimes these could be sterile, there could be no microbes in here at all, and some or they can be infected with some kind of a microbe. And the valves, do the valves have a good blood supply? No, they don't. They do not have a good blood supply. It's also kind of like tendons, for example, the sinuses, places in our body that don't have a good blood supply. So when it comes to treating these conditions, and for example, in the valvular area, it takes a really long time to be able to penetrate that and hopefully to eradicate that infection. Just like when you have a sinus infection, you have to take antibiotics for a longer period of time than you would, say, if you had an ear infection. And also tendons, they don't have a good blood supply either. So the next slide shows us the pathophysiology associated with infective endocarditis. And I think pretty much we talked mostly about that, but I want you to be thinking about where would the embolism go if it's on the left side or the right side. So we can just go down, and this is probably in your textbook, and we've already covered all of this. And I already told you this. So if they come out the left side, this is how we get an emboli in our brain. That's what causes us to have a stroke, or in our limb. And we're going to be talking about that with our Oslers and our Janeways and our splinter hemorrhages. Those emboli can lodge anywhere. They can lodge in your kidney and cause, renal failure or renal insufficiency at the very least. They can cause embolism in the liver, in the spleen. They can infarct anywhere. And then on the right side, of course, it's going to travel right into your lungs after it leaves the right ventricle. So this is just something that I want you to be thinking about. Management. We are going to manage these people with anti-inflammatories, but most importantly, antibiotics. Okay, we're going to move to the next slide, which is part of our case study. So I want you to take a minute. I'm going to set the timer and read the nursing orders. Okay. So you got those nursing orders. Our next slide is going to be vital signs. This is your vital signs. I want you to pay attention to the blood pressure and to just all the vital signs. And I want you to talk. Ooh, that's our timer. I set it for over a minute. Okay. So your patient is oriented ×3. He knows, but he is drowsy. He does have a murmur, has a grade 3 or 4 diastolic murmur. His lungs are auscultation. His abdomen is soft with a slight left upper quadrant tenderness. He has multiple petechiae on the skin, arms, legs, and chest, and he has splinter hemorrhages under the nail bed. So first and foremost, what do you think of these vital signs? What do you think about a patient who's laying down that has 152/48, and when you sit him up, he has 100? He has a higher end blood pressure. But what do you think is happening here? It's orthostatic. Why do you think? And he has a high heart rate, right? So we're thinking. Are you thinking compensation with that heart rate? Why do you think his heart? Yes. Okay. So I want you to be thinking about, in our case scenario, what can be for that too. Mo, it could be definitely because he has an infection. So since you brought that up, what do you think about this temperature here? Don't these patients normally have a high temperature? They normally have a high temperature. So who are the people what are the groups, I should say, of people who may not show us the temperature that we expect them to have? The elderly, right? The elderly, and who else? Immunocompromised people, people that are either have immune cancer patients, anybody who has an issue with their immune system, anybody that's on steroids. I want you to remember that, because that's going to be pervasive throughout your career, and it's going to be pervasive when we're talking about these conditions as well as when we get to cancer. So sometimes, we think, oh, well, things aren't too bad. She's only got a temperature of 100.2, but her body may not be able to mount that response that you and I are looking for. So we may think, oh, things aren't that bad when they really are. So that's why we got to look at the whole picture here, because this drop in vital signs is it would be worrisome to me. So what could be some of the causes for orthostatic hypotension in this patient? I'm gonna go over here to my slide. What drugs are you talking about? Whoever said that. Which ones though? Which ones? Do you need me to go back to that slide? Okay. Will the beta blockers? Okay, I'm gonna go back to this slide. Okay, so the beta blocker is metoprolol, right? So and Norvasc, yes, there it is, amlodipine. So we're going to talk about metoprolol because that's going to be the one that's the strongest, okay? So what is metoprolol what's its primary effect? What's it going to control? The primary effect is heart rate, okay? It's a beta 1. Blood pressure is a secondary effect. Okay, so calcium channel blockers and beta blockers, their primary effect is to control heart rate. And they also control blood pressure, but their primary job is to control heart rate. So we see, I don't remember what the heart rate is, I think it's 116. So because this patient has Norvasc and has metoprolol on board, it's a true possibility that that's not even a true heart rate. So that's one thing. What else in this patient's scenario and in his drugs, because you guys said drugs could lead to this kind of deficit in blood pressure? The Lasix for sure, right? Now I want you to think about what was going on with your patient when they came into the ED. What did they complain of? What has been happening? Infection. Okay, so are you thinking sepsis? Is that why you say infection? Temperature, okay. But what specifically? So these are like little pieces of the puzzle that I want you to try to get, okay? So your patient has been, we've talked about this here two times, once in the first paragraph and then once in the second. So relentless nausea and vomiting, relentless retching and vomiting. I don't know if I told you guys this the other day when we talked about hypovolemia. But when your patient comes in, you have to investigate because what's a lot of vomiting to you may not be a lot of vomiting to me, and also diarrhea. So don't forget that your patient is vomiting. They feel bad. They have a fever. They have incidental water loss with that fever. So they're losing volume there. and they are also losing volume with vomiting. Okay, so we don't know if the patient is able to keep fluids down, so they could be hypovolemic. So that's why getting a good history is super important, and reviewing their drugs is important, because if a patient's vomiting or have diarrhea, they don't know, hey, I should probably back off of my Lasix. They just don't know those things. They're going to take whatever they're told to take. And here, and also in our nursing orders, what are you going to do first? Are you going to give this Vanco and Zosyn, or are you going to get these blood cultures first? What comes first, the chicken or the egg? The cultures. The cultures come first. And Racine, why do they come first? Because I might think that my antibiotics are more important. I want to kill this bug. Why do you say that they're first? Yeah, because if you give the antibiotic first, you're going to decrease the bacterial load in the blood. And so we might not be able to ascertain what that organism is, and we won't be able to adequately order antibiotic therapy. So very good. Awesome. Okay, I want to go back to this slide. Okay, so this is a test your knowledge. Which of these statements about IE are true? Select all that apply. Definitely, definitely. Okay, so it can affect the heart valves. It can affect the, any part of the heart, the septum. It can affect the chordae tendineae, and it can affect the valves. And it is the innermost layer, the endocardium, and it can lead to heart failure. It can lead to sepsis, and it can lead to dysrhythmias, which we're going to talk about next week. So we talked about orthostatic hypotension. So I already talked about this. Consider the effects of vomiting on fluid status, and consider the effects of furosemide on fluid status. So remember that those things don't go well together. So if I have a drop in volume, I'm going to be tachycardic. My tachycardia could also be increased with fever, whoever said that as well. So those are great, that's great critical thinking there. Next slide. Okay, so let's talk about the significance of the abdominal tenderness, hematuria, joint pain, and petechiae. So why do you think your patient could possibly have pain, abdominal pain? And I think it was left upper quadrant, right? The spleen. Yeah, you could infarct the spleen. You can also infarct the liver. And the mesentery, actually. So you can get infarction anywhere, but that might explain why your patient has abdominal tenderness. What about hematuria? So in any of these areas, you can have embolization. So you can have embolization in the abdomen, like I talked about, liver and spleen. You can also infarct the kidney. You can also cause and what I mean by an infarction is that you can have a traveling thrombus, what we call an emboli, that lodges somewhere in the tubules of the kidneys that can cause some acute renal failure or insufficiency at the very least, which will cause a decrease in urine output. And they can also have joint pain. You can infarct the joints as well, cause emboli in those joints that will lead to arthritis. And then we're going to talk about petechiae. What is petechiae? What is petechiae? What's the definition of petechiae? Okay, spots. What kind of spots, guys? Tiny red spots. They're pinpoint bruising on the skin. Yes. So really, they're caused by microembolisms to the small vessels. That's what petechiae are. But you know, sometimes it's, you know, they're tiny, tiny, tiny little bruises, and they're scattered and they can be scattered all over the body. And so they basically are bruises, but they're so tiny. And sometimes you can overlook it because it looks like a rash. But people that have low platelets, for example, will have petechiae. In this case, we're talking about throwing little tiny clots into the capillary beds. That's what we're talking about. So if we're talking about hemorrhages and microemboli, what are some of the signs and symptoms of your patients that you're going to see with throwing these clots, besides the things that we just mentioned? What are the things you can see? Splinter hemorrhages. Mo, what is that? What are splinter hemorrhages? They're fingernails? Yes. They're reddish brown streaks that are linear on the nail beds. And so they kind of look like if you've ever gotten a wood splinter underneath your nail bed, they kind of look like that, but it would be a whole lot of splinters there. Okay, so what else can you get besides splinter hemorrhages? What else? What other signs could you see? Osler's nodes. Okay, so what are Osler's nodes? They're painful. Okay, what else? They're painful. Okay, so let's go back to the Osler's nodes. And you're right, there's Janeway's, and that will be our next slide. But let's differentiate Osler's nodes from Janeway lesions. So one of the main things is one is painful and the other is non-painful, right? So Osler's nodes is painful, Janeway is not painful. And so the Osler's nodes, they're painful. They are red or purple. And somebody said pea size. They're small, about that size. They are slightly raised, okay? And they can be found on the fingertips and on the toes. So that's what we're seeing right here, okay? Now Janeway. Let's talk about Janeway. Janeway are non-painful and they're flat. They're flat lesions. And they're irregularly shaped, just like you can see here. They're irregularly shaped. They're small, they're red spots, and you usually see them on the palms of the hands or the soles of the feet, on the fingers or on the toes. So you need to know what you're going to see in your patients with infective endocarditis. What else that you are not going to be able to see, but what can happen to your patient? And you know, in the Janeway's, oh my gosh, what was I going to tell you? In Janeway's, in their lesions, sometimes the center of them will be kind of white or clear. That's what I was going to tell you. What is one more thing that you need to know? One more thing that you need to know about the signs and symptoms of infective endocarditis that you're going to see, that the provider will see. Roth spots. There you go, Roth spots, which are these hemorrhages that are behind the eye that you and I are not going to see unless we look. You'll have to dilate the eye. They're retinal lesions, so you got to dilate the eye and look behind the eye. So this is what it would look like if we dilated that eye and we looked back into the retina. We would see all these little hemorrhages. Okay. One thing that I want to make sure that you know is that you are able to differentiate where your stethoscope would be if you are going to auscultate any valve on the chest. Okay, so what is the valve on the right side? What is this valve right here? What valve is this? Aortic. What's this one? What's the one directly across from it? Pulmonic, okay. What's below pulmonic? Herbs. What's below herbs? The tricuspid valve. And then the one that's fifth intercostal midclavicular line is the mitral valve. Make sure that you know where to put your stethoscope on somebody's chest and which valve you're listening to when you move it. Okay, when you move the bell or the when you move your stethoscope. Okay, make sure that you know what valve you're listening to. Make sure that you know that S1, what you're listening to in S1 and what you're listening to in S2. We talked about that last week. Okay. Let's see. Okay, so we already talked kind of a little bit about this, but you're always, when you know that the patient has infective endocarditis, you're going to be looking for embolization, right? That's going to be the thing that you, the nurse, are going to be looking for all day. So you want to be looking from head to toe. What will you see in the neuroassessment? You're going to see changes in neuroassessment. It could be changes in level of consciousness. It could be verbal. It could be a visual. It could be with balance, like ataxia. Sometimes these patients will have TIAs, or they'll have strokes. Some of the things that you need to be listening for with regard to the cardiac systems, these patients might have a new or a worsening systolic murmur, for example. So I want you to go down, the list of the systems, and I want you to be knowing what you should be paying attention to for each one, okay? Diagnostic criteria. Okay. So we already talked about blood cultures, right? We already talked about, that's the biggest piece of this. If it's going to be bacterial, we need to know which organism it is. We can also be concerned about murmurs, like I just told you, systolic murmurs. We can have cardiac dysrhythmias. Eventually, we can have cardiomegaly that we're going to see on chest X-ray, and of course, we're going to have fever. Duke's criteria, yes. So, I'm not going to ask you those kinds of things. I do have Beck's on this slideshow, but I wouldn't ask you it that way on the test about Beck's triad. Anyway, I hope I wouldn't forget to do that. So, I wish that I could show you guys videos on Blackboard Collaborate, but I can't. The platform does not allow me to do that. So this is a pretty good video that I found on, I think it was on YouTube, and it just kind of shows you what the transesophageal echocardiogram is. We talked about it with valvular diseases, but this is one of the direct visualization of the valves is a transesophageal echocardiogram. And so I would want, if you have a minute, just look try to find this video and see if you have never seen one before, this will give you a good idea of what a TEE is. And so we want to directly visualize them so we can look for any vegetation on those leaflets, or maybe, and sometimes we use it for other things too, to actually find PFOs. But it's mainly what we're doing in this situation is direct visualization of those valves. So take a minute to look at that. Let me go back to my slideshow here. Okay. So this is progression of our case study. So take a minute and look at the labs and let me know what you think about them. I have hemoglobin and hematocrit obviously switched here on this slide. I just realized that. What do you think about these labs? Does anything bother you here? The kidney and anemia, okay. BUN and creatinine are elevated, right? So that would definitely happen should we have an infarction, right? Or this patient already has renal disease, we know that, right? But it could be further complicated from infarction. I got to go back to the chat box to see what you guys said. Glucose, what do you think the glucose is caused from? The elevation in glucose? Could be a stress, could definitely be stress, could also be a consequence of infarcting the liver as well. And somebody said that, yes, infection, for sure, that's a stressor, that's a stressor. And somebody said, so the H&H is on the low side, right? So we have to be thinking about why this patient would be low. What are some of the things that you can think of why this patient might be low? There's three things I'd want you to be thinking. Renal, and why would the patient, what does renal have to do with anemia? What's the rationale behind that? What's missing? Erythropoietin. So they manufacture less, or which is a direct messenger to produce red blood cells. So if the body's not making erythropoietin, we will have a decrease in our RBC production. That's one reason. What's another reason? What about these microemboli? The microemboli can also be causing that. And remember that this patient has chronic illness, so it could be anemia of chronic disease. So that is going to play a big role in the reason why the patient's H&H is so low. So your patient here has long-standing history of malnutrition and is receiving TPN. Is it necessary to perform blood glucose levels daily on a patient that is getting TPN continuously? The answer to that is actually no. There we are. The answer to that is actually no, because when TPN is given continuously, the pancreas is not being stimulated to produce insulin like it is when we get a bolus feeding. So it's not necessarily needed, but I can tell you that in the hospital setting, you will be doing blood sugars every 6 hours, and you will have a sliding scale for that. But think about that. You know, if you're fasting, what happens? Is your pancreas producing insulin? But this is like steady, continuous infusion of TPN. I don't want to confuse you. And you probably have been taught no rapid insulin, right? Yes, that's not needed. I mean, unless the patient is hyperglycemic for other reasons, okay? But if your patient's in the hospital, more than likely they're going to get a sliding scale. Okay, let me see. At a slow rate, yeah, continuous slow rate. There's no bolus feedings. Okay, so what is one of the NANDA risk diagnoses that you would want to monitor for once we rehydrate this patient secondary to hypovolemia? Hypovolemia. What's one of the things that you're going to be the nurse? What's your risk diagnosis? What's your NANDA diagnosis? Risk for hypervolemia, right? Risk for fluid volume overload. That's how you would say it. That's how you would say that. You guys are writing NANDA diagnosis, right? When you go to clinical? So and remember what I told you guys in our first lecture when we talked about volume, we talked about hypovolemia. A lot of times when a patient is hypovolemic, we're going to resuscitate them with crystalloids. And we don't know exactly how much to give them. We just want to increase stroke volume, increase cardiac output, increase perfusion. And we try to do it in a judicious way, but sometimes your patient can get fluid volume overloaded. So you as the nurse need to be monitoring for risk for fluid volume excess. And so when that happens, somebody said lungs. So that's what you meant by that. You meant that if your patient gets overloaded and they have too much fluid, they're going to end up in pulmonary edema. And then what are you going to see in pulmonary edema? You're going to hear crackles. You're going to hear crackles. You might be able to see that on chest x-ray. You're going to have rales. They're going to be coughing. They're going to be dyspneic. They're going to be coughing up some frothy sputum. All right. So they're not going to be able to adequately oxygenate because they're going to have intravascular volume. It's going to be increased. Okay. So these patients can also have, JVD, but if they have JVD in this situation, they're going to also have rales because the JVD is related to fluid volume overload. And if they're hypoxic, of course, they could have changes to their LOC. All right, so I want you to be thinking about what the consequences of fluid volume excess are. And then the last slide for infective endocarditis is I want you to be thinking about treatment. How are you going to formulate SBAR for handing off, for giving report to the oncoming shift? How would you handle that? Treatment, of course, is going to be based on what the organism is. Most of the time we give Rocephin and vancomycin for that. And don't forget that as one of the main functions of your job will be for patient education. And so what are you going to do to educate these patients? How are you going to educate them? What are some of the things? Finish the dose. Finish it. Please finish it. Finish your antibiotics because it can lead to antibiotic resistance, right, if you don't do that. And of course, we know that they're going to be on antibiotics for the duration. They're going to go home with antibiotics. They're going to have a home health nurse or somebody's going to teach them how to self-administer these antibiotics. So they are going to have long-term antibiotics. But you're going to have to teach them about prophylactic antibiotics, okay? So think about that. Prophylactic antibiotics, they're going to need to have them before they have a dental procedure, for example. If they have any kind of, they're going to have anything done to their respiratory system, like a biopsy or a tonsillectomy, for example, that would be something that you would want to teach them. Or if they're going to have any kind of a procedure where they have some infected skin or skin structures or any kind of musculoskeletal tissue, that we would want to prophylax them. And dental work is really a big one. Okay. So let's move on to pericarditis, and we're going to first talk about the pericardial sac. And if you remember or you've read, you know that the pericardial sac is in two layers. The outer layer is that fibrous pericardium that anchors the heart to the mediastinum. So it's very protective in that way. And that fibrous layer also prevents the invasion of microbacterium to the myocardium, for example. It prevents the heart from overstretching. And in between those layers, we have serous fluid. And that serous fluid acts as a lubricant so that when the heart is beating, there's no friction at all. And you probably know by now that when we do have an inflammatory process in the pericardium, one of the hallmark signs that you'll hear is a pericardial friction rub, because it sounds like sandpaper. And we'll talk about that here in just a second. But that's a very important part of the pericardium. So what causes What causes the pericarditis? What causes pericarditis? What are the potential causes? Fluid. Okay. We're talking about inflammation, aren't we? We're talking about inflammation in both And you know what, Alexa, you can have a bacterial infection with pericarditis, but usually it's not all. This is not the one that is infectious. Okay, most of the time. This is not the one that's infectious. It can, not that it can't, because it can have you can have a bacterial or a viral illness that causes pericarditis, but usually it's an inflammatory process. It comes as a result of some kind of trauma. For example, we see it in patients who have an MI. We see it in patients who've undergone cardiovascular surgery, who've had some kind of physical injury. So it's an inflammatory process. And you know that whenever we have inflammation, all the chemical mediators come to the area to try to defend it, and that's what happens. We create that inflammatory process in the pericardial layer. Now we also have one of the other risk factors is autoimmune diseases, and especially lupus. And sometimes we don't know exactly what causes it. So what are some of the signs and symptoms that your patient with acute pericarditis might show up with? What are some of the signs and symptoms they might show up with? What do they complain about? Oh, chest pain. So Racine, what kind of chest pain are they going to have? Sharp, maybe stabbing. What about radiation? Neck, arms, shoulder, scapula. What does that sound like to you? Sounds like an MI. So we got to differentiate, and that's why everybody gets all freaked out when somebody comes in complaining of chest pain. And also, these patients might have ST segment elevation on their EKG strip that may also further make me think that this patient is having an MI. All right. So you know that your patient's going to have pain. Pain is going to be one of the biggest complaints that your patient's going to have, chest pain that radiates. What else are they going to tell you with regard to that pain? It's going to be on deep inspiration, and what else? Worse when they lie down. So position is also important. Okay, positioning is also important. So when they're lying down, they're going to be in greater pain. So how would you as the nurse help them alleviate some of that pain if you know it's positional, if you know that it can be positional? You're going to sit them up, and what else? You're going to put them in the tripod position. You're going to put them in high Fowlers, and you're going to put them in the tripod position like you would put one of your COPDers, right? Don't the COPDers sit in tripods so that they can expand their chest? And you're moving that heart away. So you're moving it in another direction, so it decreases their pain. So don't forget about the tripod position. How are we going to manage these patients? What do we do to manage them? We're going to give them what are we going to give them, nurses? What are you going to give them? NSAIDs. Yes, non-steroidal anti-inflammatory drugs. Okay, and that's the main thing that's one of the things that's going to help them with their pain, because we're decreasing that inflammation that's causing this pain. So NSAIDs is one thing. What else can we give them if the NSAIDs are not actually working too well? What else can we give them? Well, you can give salicylates, aspirin. What's my least favorite drug that we give all the time? How about some corticosteroids? Yes. You can give corticosteroids in patients that are refractory. You can also give a drug called colchicine that we're going to talk about later in the semester, which helps with decreasing inflammation as well. We use it it's most commonly used in gout, but you can also use that. And of course, if it's identified as bacterial, we're going to go ahead and treat it with antibiotics, obviously. Okay, so we have acute pericarditis and we have chronic pericarditis. So when we're talking about chronic, one of the things that that can happen with chronic is that fibrous layer that I'm telling you about of the pericardium can thicken. And if it thickens, it's going to cause constrictive pericarditis. So that's something that we don't really want to happen because it's going to affect the pumping action of the heart. So that is one of the issues that we have when we talk about somebody who's going to have chronic pericarditis, defined as an inflammatory process that lasts greater than 6 months. So what are the two complications of pericarditis that we're concerned about, and one that can be life-threatening? What are the complications of pericarditis? Tamponade. So effusion, pericardial effusion, and which can lead to tamponade. Okay. So our last case study is going to be on cardiac tamponade. So I want you to take a minute or so to read this case study. And then we'll talk about it. Okay, I just set the timer. Okay. Tell me, what are your first thoughts here? Let's just what are your first thoughts before we talk about the wife coming to the nurse's station? What are your thoughts there just about what has happened to this patient and what the risks are? Fractured ribs, which could lead to what? Why are we always worried about fractured ribs? And more trauma, broken ribs close to the mitral area of the heart. Yeah. Why, Mo, are you worried about puncture, lung puncture? A puncture of the lungs. Yes, that's what I'm worried about when I see fractured ribs. And so Mo, I think, said pericarditis. In this scenario, what puts the patient at risk for pericarditis? What makes you think that? Of course, they do have, you're right. We know that this is a cardiac tamponade scenario. But what is it about the scenario that made you think it's pericarditis? What's the risk factor? The risk factor is chest contusion, chest trauma, okay? Remember I told you it could be traumatic. It could be an auto accident. It could be a myocardial infarction. It could be a surgical procedure. It could be, I don't know, Those are the main risk factors, but trauma is huge. And next semester, when you get to S2 and you talk about emergency medicine, you're going to be way ahead. So whenever somebody hits the steering wheel, we are always concerned. That's why there's an airbag there. You're always looking for bruising on the chest, because it depends on how hard that patient has hit the steering wheel. What's actually going to happen. Okay, so now the patient's wife, this happened, he came up at 1 o'clock, and now we're talking about 8 o'clock at night. We've had a long period of time from 1 to 8, 7 hours, where the patient is the inflammatory process is probably happening to this patient. So she's coming up to the nurse's station, and she thinks her patient has a heart attack. She wants you to come and help. And he's in bed. He is breathing, but he's cyanotic from the neck up. He does have a pulse that's rapid but very weak. What are your thoughts, nurses, about that? What would your thoughts be if when somebody does come to the nurse's station and tell you something like this, because it's going to happen? What's your first thought? What's your first thought besides, I want to run? We don't run. Come on, my critical thinkers. What are you going to do? Okay, you're going to get an EKG. Okay, all right. I can. I'm going to get okay, I love it. You're going to get the crash cart. And that would be the first thing I probably would do. Everything's going to happen simultaneously, right? Nothing happens, in a bubble. So I would what would be my first action? Of course, I'm thinking ABCs, right? I probably got an airway problem. I have a breathing problem. He is breathing, but he's cyanotic, and I have a circulation problem. So I'm going to call a code. I'm going to call a code. That's my first thing I'm going to do, is I'm going to call a code, because I need help. I mean, this is a situation that's going to go bad fast. So, and then I'm going to get my crash cart, because I recognize that this is a medical emergency. And somebody said oxygen, but you're going to it's going to, and it's not that you can't sit him up. Ooh, I don't know what happened there, that you can't sit him up and all of those kinds of things, but I can imagine that your patient is not going to be in any shape to be sitting up, and not going to be able to breathe on his own. It's going to be assisted breathing through an ET tube. All right, so you're going to have to intubate this patient, and you may have to be doing chest compressions. And so I have another slide here, and somebody said they're going to get an EKG. You definitely are going to hook your patient up to the monitor, which is going to be a continuous EKG. You're going to put him on. You're going to put him there on the monitor, because you might have to defibrillate him. Okay, so you're going to establish a patent airway and maintain adequate oxygenation. Definitely, you're going to have vital signs. You're going to take your vital signs, and you're going to assess for signs of a decrease in cardiac output or stable cardiac output, which we already know is compromised because your patient is cyanotic. So think about all of the things. That's why I tell you that if your patient's cyanotic, your patient's probably not going to be in any shape to sit up. So he's going to be in a cardiac arrest for sure. And so I want you to be thinking about when you're assessing, you're going to be assessing all those things that we've talked about with determining if somebody has adequate perfusion or not. And we're thinking about that from head to toe. All right. So that's when focused assessment comes into play. So, and you're going to ensure that your patient has IV access. And once your team gets there, and you guys get started, your patient, if probably already has at least one access if he's coming from the ED, but you need to at least have 2 large bore IV accesses because you're going to be giving fluids and you're going to be giving a lot of drugs. Okay, does that make sense? This is a medical emergency. So you always have to remember, if you're in if you are in a controlled environment like a hospital, you're going to have a lot of people around to help you. So utilize your resources always. And it's better to call for help before things deteriorate to the point where you would have to defibrillate somebody, do chest compressions, give them mouth to mouth, for example, or use the bag valve mask. You want to intervene before it gets to that point. Always, always, always. It's better to be proactive than reactive. So that's why assessment is important, and recognition of deterioration and changes in your patient is essential. Let's see. These are, you know, these are part of differential, and I'm probably not going to even go through this slide with you because, you know, of course, when that happens, if in this case scenario, if that happens at the time that it's happening, you don't know, you absolutely don't know what the situation is. You're just reacting to an emergent situation, but it could be anything from an airway obstruction. There could be internal bleeding. Anytime we have a high velocity car accident, we always have to be worried about internal bleeding, which will lead to hypovolemic shock. And we talked about that. We talked about relative blood loss. So I want you to be thinking about those. And we could have, and that's why we talked about what could have happened with the lungs. We could have had a pneumothorax or a hemothorax where blood is collecting in that lung. The patient could have had a myocardial infarction like his wife suspected, for example. He could have thrown a clot. He could have had a pulmonary emboli. He might have had a tear and had an aortic dissection, or he may have developed pericarditis in that 8-hour period, which has subsequently developed into cardiac tamponade, which we know is a medical emergency. Because when pericarditis, when the fluid fills up in that layer, in that sac, and it becomes larger and larger and larger, it's going to impede the pumping action of that heart, okay? So basically makes it ineffective. Let's see. I'm missing part of this. Okay, so what are we going to, we're going to have, let's see, what does this thing say? The client is intubated. Okay, so we're going to talk about triad. That's what this is Beck's triad. Sorry that that's cut off. I'm not sure why. So what are the components of Beck's triad? And I'm not going to ask it to you that way. I'm not going to ask it to you as Beck's triad, but I want you to know what the hallmark signs of tamponade are. What are they? Hypotension, significant hypotension. And okay, with muffled sounds. Okay, so Mo, tell me about the JVD.
JVD is the distension of the neck, right? So it's when you have fluid loss. It's hypotension, but it's fluid loss that affects the neck. So you have like a neck vein.
Okay, but what? Okay, so is your patient going to have pulmonary edema?
Yes.
Actually, they're not going to have any rails. That's one of the significant things about tamponade. So your patient, you know, like what we just talked about earlier when I talked about let's see, just a little bit ago when I talked about JVD with crackles in the lungs. In this scenario, your patient will have distended neck veins, but they will not have crackles or anything of that nature. Okay, you'll have distended neck veins and muffled heart sounds. So Beck's triad is distended neck veins, muffled heart sounds, hypotension, and the possibility of pulsus paradoxus. So what is pulsus paradoxus? What's the definition? Low diastolic, I think that's what it is. Ah, okay. So you're going to, so tell me about that. So when your patient takes a deep breath, what happens to systolic blood pressure? Yeah, the systolic blood pressure drops by at least 10 millimeters of mercury. All right. So that's when you'll see pulsus paradoxus. Cardiac tamponade is when the sac, the pericardial sac, either fills up with blood or some kind of fluid, and that pressure, the volume and the pressure just increases and increases and increases until it impedes the ventricular filling ability and causes hemodynamic compromise and instability. That's really what happens. Your patient becomes unstable as a result of all that fluid that's collecting in the pericardial sac, and it's impeding the heart from pumping. So your patient will have hemodynamic changes. Their pulse will be weak and thready, and they're going to be very hypotensive. Let's see. What's the most likely reason that this patient developed tamponade? We already talked about it. He had blunt trauma to the chest. He had a cardiac contusion, and he also had the fracture of the fourth and fifth ribs. So that's the main reason. So what do we do about pericardial effusion with tamponade? How do we relieve that? Ah, I love that. Does Lewis tell you the window? Pericardiocentesis, right? Yes. So pericardiocentesis is where they'll go in with a large needle, and they will penetrate the pericardial sac, and they will evacuate that fluid so that you can improve filling time. And if you improve filling time, you improve cardiac output, and you improve perfusion. So what is the risk? I think it's Mo. Mo said it. What is the risk of just doing a pericardiocentesis?
So are you asking the risk? Can you hear me?
Yes, I hear you.
So risk, it could be hematoma, infection. Is that what you're asking? Or you're talking about more about recurrent? It could happen again. I don't know what you're trying to ask me.
Yeah, and you're right. And the first two are right, but I want you to be thinking about reaccumulation of fluid. Those are the things you need to monitor for. And so tell us about why the window is a better option than pericardiocentesis. What happens with the window in comparison to the needle puncture? Do you know?
Is drain inside the cavity is we not just injected out, is just drained to the, I guess, the cavity of the body.
Yes, you're right. So you make a right angle. So they make a right angle in that pericardial sac, and they allow it to be open and to drain. And so that fluid, as if it's going to reaccumulate, it's going to drain out of that sac, and it's going to drain into the abdominal cavity. So that is a better option, and it decreases your risk for reaccumulation of fluid in that pericardial sac and recurrence of tamponade. Okay, so most of the time, that's what I see. I see a window over pericardiocentesis. But that is, either way, you got to remove that fluid to improve ventricular filling time. All right, and function, cardiac function. And if you have a chance to go on YouTube, I had this this for you guys, but I cannot show it to you rather, because of the platform that we're using. So, you know, if you're drawing out that fluid in the pericardial sac, and if it's bloody, you know, you would want to know whether if it's clotted versus unclotted, because if it's unclotted and it's coming from the pericardial sac, there's no fibrinogen, right? So the heart is going to keep it moving too. So you're going to have less, there's going to be less ability to coagulate if it's coming directly from that inflammatory process. Okay, I'm going to have you do this little math problem here. Can you do this math problem? I'm going to give you a minute and a half to do the problem. Is that 34 milliliters per hour? You know what I'm going to do instead of, yeah, you are missing, I just looked at it, you're missing some info. I'm not sure. I'm going to send that to you guys I'll send this to you on the announcement board. So just leave this one alone. Just leave this one alone for right now. So I'll send you what I want you to, to do for this particular test, because I actually messed this question up. That's on me. Okay. Something is wrong with my slide deck here. I have something wrong with this slide deck. I must have the wrong slide deck for you, this last part. I'm not sure. So basically that's going to conclude our lecture for tonight. I'm going to fix these slides here, so there'll be the last 5 slides will be for you to review, and we'll go over the answers when I see you on Wednesday from 44 to 49. I will fix those. I'm not exactly sure what I did here. I probably tried to put two PowerPoints together, and I don't know what I did, but I will figure it out. So I will fix 44 to 49 for you, and then we'll talk about it on next Wednesday when we come back together. Do you guys have any questions before we go?